Yes. Hello. Hi. Hi, Ron. Hi, Alex. It's a pleasure to participate with another live case. This is a very interesting case that I will present to you. In my side, I want to introduce Dr. André Spadaro, who
Hello.
helped me. There is a fellow, Fábio Trentin, and I want to talk with this case, to present this case with my fellow Dr. Victor, that will present this case for you. Victor, you can show us the case.
Good afternoon, everybody. I'll present this case today of a 76-year-old female with a history of hypertension, hypercholesterolemia, and no other comorbidities, who presented in September of last year with a non-ST elevation myocardial infarction in another hospital, which was at first treated conservatively, and then at discharge referred to Incor to us for an elective study of the coronary anatomy. Well, as you can see in this picture, there is a severe proximal left circumflex lesion, also in the proximal and distal segments of the LAD, severe lesions. The proximal segment of the diagonalis, also a severe lesion. You can see all the lesions in this projection here. We calculated the syntax score of this patient, which was 31, and the estimated error score 2 was 1.3%. The global risk assessment of this patient was a low risk, combining the two scores. And this patient currently was referred to CABG, but refused CABG and was maintaining medical therapy alone for a few months. Currently is presenting with anginal symptoms, limiting symptoms, and is fully medicated with dual antiplatelet therapy, atorvastatin, atenolol, nitrate, and losartan and lodipine. That's the clinical scenario for today.
Okay, Alex, do you see the case? It's a very complex case. It's a 3-arterial case. The patient is very thin, and I want to present now the scene. André will show you.
Okay, basically, the coronary angiography she performed was like 6 months before, so we were afraid that something would have changed, but what we see is basically what it figured out in September. So a very severe lesion in the LAD, in the proximal, and then a focal lesion from the mid-distal portion. And if you could just move forward. And here you can see the lesion is in the intermedius and in the circ. It's basically what Dr. Victor has showed you. If you just go forward, just another view to see how severe the lesion in the circ is. It's a long lesion. Next, please. And the RCA, you have a long lesion too, and in the mid portion you can see a more tight lesion. And so we have worked a little bit already, and Marco is going to show you what we have done so far.
Because there is a lot
the
of
syntax
lesion,
score, Marco.
Alex, and wrong.
31?
Sorry?
31, Alex.
31.
31.
Borderline.
But the global
And the patient
low
refused
score.
CABG.
Slow.
Because the Euro score is 1.3. So
Yes. Because there is a lot of lesion, then we start with the right coronary. You, first of all, you make a OCT study, then Daniel Chamier show us. You can show the OCT in the right coronary.
Okay, because, Alex, of the length of the lesion in the right coronary artery, we had to perform 2 runs of OCT, so I'll ask Danielle, please, to show us the first one, the distal run.
You have also a
Okay.
aerial
So this
view
is the
of the right. An aerial
sorry?
view, because we want to assess the lesion from both views. So, oh, this is the OCT already. Okay.
Oh, I understand.
That's okay,
Actually,
we'll
because
see
we
the
were actually preparing for OCT, we didn't take that shot.
You are seeing the image of OCT? It's perfect, Alex?
As we can
see
see.
very well.
You see it? So this is the distal
Yeah.
RCA.
Is the first run?
And you see at this point, then Danielle's going to put the bookmark. We have an MLA of this 2.1, okay? Actually, angiographically, we thought it was a moderate lesion. We were not planning to treat it, but we saw this area MLA of 2.1. And then I think if you could just move to the second run, so that we can see that the lesion that is more tight and the lesion that is close to that marginal branch. So what we are going to see is a lesion of an area of 1.1 MLA at that point that is more stenotic. And then just before the emergence of that marginal branch, we also have an area of 2.8, if I'm not mistaken. Is that correct, Daniel? Yeah, 2.8.
Yeah.
So Mark is going to tell
Yeah,
you what
interesting
we have
to see
done,
here in
and if you
FFR.
want to discuss the case.
Then because that, Alex, you decided to treat all of lesion of that artery to put 2 long stents. We started in the distal part to put 29 in the length millimeters, and to complete with 3.5 to 33 millimeters. It's a very
If you
long.
can show them.
Marco,
That
what is the
I
real
show
value
you.
of doing OCT before stenting, pre-intervention? What is the real value of OCT there?
Yes, because you decide here, Alex, because you have a doubt in the distal part. There is a moderate lesion, intermediate lesion. Okay, then you do the diameter is 2.1 that you show you. Then you decide to treat. I think it is it's the first time that I used OCT as said, and that you don't need to occlude this artery. It's very, very, very easy to do it, and the information for us is very useful. Then I think probably if I have this technology, probably in the future using almost cases, because the information that you get is perfect.
Yeah, the image is crystal
The
clear.
image, you saw the image, it's perfect. Then you decide to put the stents. You pause dilatate until 20 atmosphere, and then after you run again the OCT. Danielle can show us.
Yes. Just remind you, these are both drug-eluting stents, are 2 Firebirds with the sirolimus from Microport.
The stent is perfect, goes through the artery very easy.
Yeah, we can see now that the stents started, very well expanded with very nice apposition. We felt very satisfied with the results.
Yes, big lumen, no malposition, it's perfect.
Which is interesting if you're using those modalities for imaging. So QCA, if you do, usually you get a smaller diameter. If you do IVUS, you get a little bit larger diameter. And OCT tends to be also a little bit smaller, I think. That,
You know, I have some
compared to
difficulties to analyze apposition with OCT, complete apposition, because you know there is this shadow behind. You know, every metallic strut you see there. So sometimes I'm not 100% sure if the strut is completely opposed. Do you see this as a limitation, Ron?
I'm not so sure. I mean, I think that the only indication that their FDA gave right now to OCT is for stent deployment. But I think there are many issues in terms of sizing based on OCT. Here you can see it's very well expanded. And also, what is the meaning that you don't have one strut opposed? You don't have to do anything with it, I think so.
Yeah,
so I don't think
it's one or two, and if it's just perhaps 2 or 3 millimeters.
Have you seen this image very nicely, the shadows that you were referring to?
Should be fine. And the other thing is that can we calculate lesion length based on ACT? Is the pullback predictor for that? Mark, perhaps you could ask Daniel with C7. Can he calculate lesion length?
Actually, he measured in the 2 runs. We got a landmark, and so we did the first run and the second run. If I'm not mistaken, you can correct me, Daniel. We had 24 and then 28 of length.
46
46 total, actually. 46 total.
You mark from the right marginal is the run again, and there is a marginal, a right marginal. Then I run the others and calculates 46. It's fantastic.
Yeah, you see this little marginal.
But I want to see some practical
We use it as a landmark to calculate.
Now with C7, it's extremely easy. It navigates short monorail, but there is cost associated. So a shock. Would you use OCT even? Like, it's easy to use, beautiful images, but are you more familiar with IVUS perhaps?
No. Yeah, we have OCT and we've been using it more and more, but I tell you, I'm still not able to fathom it as clearly as, well, I derive information, I just don't know how to act on it.
Mm-hmm.
And I think it's going to take us time to really see whether we should act. Just like you're saying, stents opposed, not opposed, should we do something? We're just seeing so much more now that we just don't know what the implications of that are and whether we should act upon everything which we see on OCT.
You know, there are few labs that converted 100% from IVUS to OCT, but very, very few. I think Marco Costa is one of them. Probably the only one in the US that fully converted. And there are some labs in Europe that they converted. But I'm not sure, again, that it's ready for full conversion. And plus, there is a cost involved with it. It's more expensive than IVUS.
That's right. Compared to the IVUS cap.
But the images are spectacular, right?
Oh, it's beautiful. It's beautiful. Okay, so you finished the RCA.
The image is beautiful. The result you can see the result for the angiogram. I think it's perfect. Okay. Then we